Dr. Mark Ghaly, if you don't know, was appointed Secretary of California Health and Human Services by Governor Newsom earlier this year, in 2019. In this role, he oversees the state's largest agency, which includes key departments that support implementation of the governor's vision to expand healthcare coverage and access to all Californians. And you've seen, if you've been following any of the information that's been coming out, kind of how bold some of those ideas are and forward thinking. And I think many of us see the advantages of those. Before joining Governor Newsom's team, he worked in county health leadership roles in San Francisco and in Los Angeles. And some of the recent highlights that I want to share with you, because I think you'll see this in some of what shaped him and the kind of work that he's been leading. He's led the transition of jail health services from LA County Sheriff's and LA County Department of Mental Health into an integrated system of care. So that behavioral health theme that we've talked about in Phase 6 that many of you have been here for, you can see that touches on that. Expansion of health and behavioral health services at the Martin Luther King Junior Health Campus in South LA, including establishing the MLK Junior Community Hospital. He served as the architect of the Los Angeles County Whole Person Care Pilot, really important, the largest one, and then also in creating the county's Housing for Health program. So you can see the expansiveness of the areas that he's been interested in and influenced. So please join me in welcoming Dr. Mark Ghaly.
I learned that a long time ago.
Okay.
So thank you for inviting me and letting me come share a little bit about what we're up to at the state. Just by quick show of hands, how many people are sort of on the provider side? I don't know who's in the room. Okay, so many. How about like payer plan side? Okay, so it's a mix. Anybody just sort of in policy and foundation world? Yes, foundations. Okay, so we have a good mix. Yeah, you're not sure. I mean, which one am I? I kind of support all those people. So I'm going to try to do a quick run through of what we're up to at Health and Human Services, talk a little bit about the governor's vision, layer a little bit of my own interests onto that, and hopefully have a meaningful conversation with you all about what you see as the needs and how we help support each other to get to a healthier California. And I'll just say, you know, it's fun to see some people in the room. There's friends from med school, people who I worked with in San Francisco, people I worked with in LA. So it's always fun to come back to these environments and share war stories from all the clinic improvement work that I had a chance to do a while ago, and then thinking about how to do it at a larger system level in the county of LA and now at the state. So these are reminders about how far we've come as a set of health providers for really low-income and middle-income people across the state. So, you know, there's a theme. The governor has picked this sort of California for all theme. And I think it really carries just about to everything that we can think about, whether it's immigration issues, health issues, justice reform, early childhood. In his mind, which I very much appreciate, it's all interconnected. And as a health provider who worked in tough neighborhoods where social determinants, even before we called them social determinants, were in your face every single day, and you're wondering how do you deal with that, it's a real privilege to work for somebody who gets that interconnectedness. So, who we are a set of 12 departments, 5 offices at Health and Human Services. We have about 34,000 people working for us. And like you heard earlier, we're the largest both in size and in dollars, that we oversee $163 billion budget a year. 106 is within the Department of Healthcare Services, right? So Medicaid and some of the other programs make up about $106 billion of California's budget. And this notion, you know, any new group comes together and you talk about what you want to do, and we've landed on sort of this idea that together we must work with counties, cities, and communities to make California a healthy, vibrant, and inclusive place to live, play, work, and learn. So really one of the transformations I've had the privilege of participating in is really taking a agency with these loosely connected departments and try to figure out how we integrate them. We spend a lot of time in healthcare, how do you get behavioral health and physical health integrated? Oh yeah, what about substance use disorder services and that conundrum? Well, this is at a different and equally important level of integration. So who do we serve? About 13 million people across the state. 13,000, I asked my team to put this on the slide because people often overlook that we run this set of state hospitals that lives on the fringe where, frankly, some of the sickest, most overlooked people end up. 13,000 people in that system, 1 million people in CalWorks, IHSS, a big county program that sort of lives at that intersection between health and support services, over 500,000. You can see that the other big thing is food support and 4 million people getting CalFresh. So we, for the first time in a while, came up with a set of strategic priorities for HHS. And I often say when people say, well, what are your priorities, Mark? And I said, have you seen who I work for? Right? He has a ton of his own priorities, right? And it's really great to work for somebody with a lot of really priorities that align with kind of where I've been throughout my career. But the first one is really a focus on build a healthy California for all. And this is where I think we'll spend some time talking about in this group, what does that mean? What does that look like? Things like cost containment, value instead of volume, how do we make sure that we get everyone in California covered? I mean, these important questions are part of that. I've already alluded to the focus on integrating health and human services, and I've been told that I would have to change it in statute, so that becomes a little tougher, but I've even threatened to change the name of the agency to the Agency on Human Services and Health, in part because really those human services are really what fund and support people to be out of poverty, be out of some of the things that we all recognize as social determinants of health. And if we really wanted to order it in the right way, we should focus on those in some ways even more than the health piece and the healthcare piece, certainly. And I think it's more powerful to have a doc say that than somebody else. So, maybe Senator Mitchell will help float a bill to change the name down the road. And then you heard a little bit about some of my prior work, and I have come to believe in my career that if we create programs that really target the people who fall through the cracks in our systems most, that we have a chance to lift all boats. So really a focus on the most vulnerable. And we can talk about who those are later, but largely when I think about some of the most vulnerable, you don't have to spend too long in Los Angeles and some of our big urban centers to see the number of people living on the streets, and the fact that people start out homeless maybe because of affordability issues, like I couldn't make that one rent payment. You move into your car, you then get out of your car because of the anxiety and the voices that develop, and then suddenly you're chronically homeless. And that trajectory, to me, makes that group one of the most vulnerable. Talk about justice and health issues. The fact that we have a broken behavioral health system in large parts across the state means that the jail bed is the bed that never says no at the end of the day, and a lot of our patients end up in jail. So that's another group. And then sadly, there's a predictable connection between kids in the child welfare system and those other two systems that I just mentioned. It is well known that kids who are in child welfare systems today, especially out-of-home placement, end up homeless at a disproportionate degree and then in jails. And we need to begin to look at those three groups and say, the story that we keep telling should change, can change, and will change if we sort of work together on it. So what are some of our sort of guiding principles? Adopt that culture of collaboration and innovation, focus on measurable outcomes and value generation, and that really follows with the fact that you need data. We have a ton of it at the state. We don't organize it as well as we can and should, and therefore we don't unleash its sort of ability to lead to action. I often say that sometimes we get so focused on patient-centered and we forget the patient in trying to be patient-centered, because really we are focused on, well, what's the funding stream require us to do? How do we jigger our system to get the funding maximized? And lo and behold, in the rearview mirror are the patients we were supposed to care about the whole time. And then the last thing, which whole person care pilots have helped us sort of normalize this language, but people have said for a while, patients, clients, consumers, call them what you want. They don't experience us as healthcare on the right side, social services on the left side. They experience their life, and we need to look at them as such. So we're going to go into a little bit, and I'll go through some of this very quickly. California has done a tremendous job since the ACA in reducing our number of uninsured, right? So this is data from CHCF. I think that some other data has showed that we've had even a bigger drop in our number of uninsured. It was as high as 18% pre-ACA. Now some people are looking this year that it's closer to 6 than 7%. And I think some of the changes that we'll talk about that the legislature and the governor did in this last session and through the last budget hopefully will make that number come down even further. Medi-Cal at a glance, 12.9 million Californians in this program. It's about a third of the state. I often say if you had Medicaid and Kaiser together, you're covering about 60% of California. Pretty amazing for a state this size that a couple of programs or providers do the lion's share. You can see most of it is managed care. There's still some fee-for-service. There's always the pressure to say, hey, should fee-for-service stay this size? Should it become managed care? You guys are familiar with that conversation. You have CHIP that's small, and then the 3.4 million is the number that have been covered since the expansion. This is just, hey, the slide shows you based on age, who's in that Medicaid program. And I think really more than ever before, it is seen as a backbone of this entire safety net and frankly, the health system. And the responsibility of running that backbone, I think also lends itself to recognizing its heft and might and trying to move the entire delivery system because of changes in Medicaid. I think it's a really powerful opportunity. National comparison, right? There's some states that have lower uninsured rates, but I think very few states have done as much in the last few years to reduce our number of people who are uninsured. And I will say, in large part, there's, when you think about the uninsured that are left in California, there's about 750,000 people who we think are eligible for Medicaid that aren't in the program. So, I think about refer a buddy, figure out like these different things to get that really hard to identify group into the program. Like we need some strategies like that. And then when you think about what Covered California has done, probably, and it's easy to say as the person who gets to chair their board, but also I think arguably most people around the country recognize the California Exchange, Covered California, as probably one of the most successful. Other people will say, well, it was the one that was most well-resourced. I was like, does it really matter, right? Like they're still very successful and those resources have gone to, I think, a lot of good. And you can see that the program has continued to grow except in this last year, when the federal government took away the individual mandate, changed the whole sense of that carrot-stick approach with subsidies and mandates. And we'll talk about some of what the governor and the legislature did to reinstitute that in a minute. So here, the minute is now. So what did the state do in this last budget? We put in over about 3 years, I think it's about $1.1 or $1.2 billion of subsidy support. And the target group, as you'll see on the next slide, is largely people in the middle, not the lowest income folks who have and are largely eligible for the lion's share of the federal subsidies, but really in the middle. And what has that done? We anticipate that it's going to increase enrollment by about 230,000 people, so helping shrink the number of people who are remaining uncovered. And what it did in a way that even those of us who projected around this, it really allowed premiums to come down in a way. So health plans that came in with their new rates for this year actually came in some parts of the state and areas of the state with almost no increase. San Diego County was one of those counties, and we went and talked about the fact that because of these things together, both the new mandate or penalty for not electing to have coverage if you can afford it, and the fact that we had some state subsidies to latch on to what the feds have already been doing, we anticipate that hopefully we can maintain this slow rate of rise on rates. So what does this actually mean for folks? So about 23,000 people who hover around the poverty level, or 138 of FPL, are only going to be paying $1 a month, right? So that's, hopefully that is enough to keep people engaged. About 663,000 people will get another $10 to $15 a month in a subsidy. That represents about a 15% discount on their monthly premiums. And for lots of us, so what, big deal. I think people living on the edge, making that decision every month, this becomes meaningful. And then a big number of folks are getting a pretty significant, nearly $120 a month support, and that's where the 235,000 sort of middle income Californians who elect not to have coverage today, we expect are gonna jump in. And in a state where we like to declare our firsts, first in the nation, we're the first in the nation to have that middle income or support for people in the middle. And I think it's created praise across the state, and hopefully we can do more down the road. The other big thing is this idea that because the uninsured is in large part undocumented in California, and you have all followed these debates and conversations about how much can and should we do, I think despite some noise, we did something I think is very important, which is tell young adults who today don't have access that it's important to begin using the system for preventative care, for primary care, so that as people age and they need more chronic disease services, that we've developed some of the patterns and ways of utilizing care that we all want to see most of our patients use. So we anticipate, I'll tell you, with public charge and that chilling effect, we're not sure that we're going to hit 90,000, but the anticipation, and it was budgeted starting in January, that about 90,000 people would be eligible across the state. And it's basically a Medicaid benefit package, right, without federal dollars. The other thing that our governor campaigned around that without a show of hands, I bet I can just tell by facial expression what people think about single payer. But that said, we've had a lot of conversation, well, are we seriously going to take a look at single payer? And the answer is we're really trying to look at unified funding strategies that take some of the things that we all lament as costs in healthcare and pivot that to patient care, right? And the single payer concepts around the globe give some promising principles on how to do that. So we will take a very serious look at what it means to have a unified financing system, a single payer system. And my way of thinking about it is based on what I'm going to call single payer principles. And many of you could spout out what those might be. I've sort of narrowed it down to roughly 10, and we'll take a deep dive on each of those 10 and try to understand where is California today, where could we go on our own, and what sort of help do we have to get to go all the way? And then really hopefully provide the legislature and the governor a roadmap to make some decisions, hard ones, about what do we take on over the next couple of years. But this will be, I think, a very exciting and real conversation in California. Again, a place where, although we wouldn't be the first state to take a look at this, I think that the level of seriousness around the conversation will be high. Let's see, I'm going to skip this slide, although I think that it's not a small number, what we spend on healthcare. This is going to be sort of the framework that we take, really, that care should be affordable and meaningful coverage, right? Like, it's easy to imagine care you can afford that you can't use, and then care you can afford that seems really usable. Like, how do you hit the sweet spot on both? Quality care, and this is really about creating a modern health workforce, expanding physical and preventative care, and redesigning, and this is, I'd be excited to engage with you all on how do we use data and technology, sorry, one slide too fast, to really drive system change. And then the last piece, which, you want to avoid being the triple aim, just said in a different way. I think one of the big changes, right, is that this sort of real, true, whole person approach. And we have the privilege in California, because next to the health piece are all of the other things that we know matter for people's lives, like the social services. So how do we begin to think holistically about all of that? So I'm going to go through these slides pretty quickly, but this idea that all of these things, as you all know, drive people's health, right? And the chicken egg question is the common, well, which came first? Were you poor first and then unhealthy, or were you unhealthy first and then became poor? And it does matter in many, many ways, but at the end, when you're in your clinic room, right, it kind of doesn't, right? A diabetic is a diabetic, and we try to solve for that. But I have the privilege now to think about all of the things way upstream. And so how do we begin to look at early childhood in a very different way? Adverse childhood events and trauma, the response to those things. You'll see in next slides this real focus on prevention, early intervention, and screening in a way, and actually putting resources into those efforts. So this, I think, is a very important slide in that many of the clients that live in one program actually live in another. And if you look, I think the most telling one is within child welfare. 1 in 10 kids in our child welfare programs, which the state administers through the counties, right? The counties do the work, we administer it. 1 in 10 kids are touching almost 10 of our services, right? And that is, not low-hanging fruit, because it's still a little hard to reach, but it is a real opportunity to say we can't have data disconnected. We can't have case managers in 10 places for the same kid. We can't accept that people, jump in and out. One thing that Hunter taught me a long time ago in San Francisco was this idea in healthcare that continuity is king, right? This idea that we really value continuity in care. I think that idea that we have kids in 10 different systems getting discontinuous services, frankly, or not connected services is a real opportunity. But you can see that it's not just in child welfare, but many of our programs have people who cross over. And this sort of screams a real data opportunity. If we can get our data together and clean in one place and find the connections, we may be able to be a lot smarter about how we use our resources and target people's needs. This is just, something, and I didn't even know I said it, but my team is so good. They're like, at your confirmation hearing, you said, siloed systems yield siloed results, and I think we all experience that every single day. So what are we doing? You're here talking about improvement in healthcare, and we've done a lot in Medicaid. We can always do more, and I'm interested in that dialogue. But in our current waiver program, right? You all know that really public hospitals and clinics have had a chance to redesign their programs through various incentives. We have the Global Payment Program, which really has supported that care for the uninsured, and a number of other innovations. The Dental Transformation Initiative doesn't get talked about enough, but the real work within Medi-Cal on supporting kids and adults to get better access and better care. And then the whole person care pilots, which are near and dear to my heart, really that opportunity to test models of glue, being the glue between care that's disjointed, trying to meet some of those social needs that we know drive people to be less healthy than we hope they can be. So I'm going to skip this one because I'm afraid we're missing. Spend a little time on value-based payment programs. So this is our first year. This is a big lift for us to go into value-based. Some of the leadership at the Department of Healthcare Services said, hey, Mark, you've got to temper expectations, right? Because we're just starting this work. And I promise that, that the legislature and the governor is going to ask, well, why haven't we fixed value? Right? Like, haven't we already addressed that in last year's budget? And it's going to take a lot of time to roll out these programs and get them into clinics and actually have the measures of value versus volume actually trickle up to the state and have something to publish. But we're excited about this over $500 million investment into value-based projects or payment programs. And they're really focused. One that we added sort of at the 11th hour, but I think is one that many of you will watch closely, is how do we actually incentivize that integration between behavioral health and physical health care, and how do we actually pay for it in a value-based way. The Health Home Program, I think, is something that, Senator Mitchell was really a guide to support the state in considering how to do this. I know many counties and plans are putting that into place now. It is something that I think is part of our continued learning on how to do this work well and how to really support the most vulnerable, whether they're homeless or in another category. And it's, I know in Los Angeles that it's sort of become a program that complements and supports what whole person care has done. And I think the lessons between health homes and whole person care are going to be exciting to distill over the months and years to come in California. This is important. I talked to you about sort of the upstream focus. We put a lot of investment right around the time Governor became governor. We had an audit around children's preventative services and the fact that many of our kids in Medicaid weren't getting the preventative care that many people thought they need, me included. And this notion that we had to spend more time not just supporting plans and monitoring plans, but incentivizing plans to do this through their provider network. So more funding going into developmental screening, and then the new focus of our Surgeon General, who really has put the flag in the state around trauma and adverse childhood experiences, and really looking to clinical folks to help screen for that and then be part of the global response. And this bold goal of trying to reduce ACEs by about 50% in a generation in California, it's bold, but I think it's possible in many ways. Covered California, I'm going to spend a minute here. I talked about how Medicaid is such a big opportunity. Covered California, smaller but really nimble and innovative. And together, these two programs are going to be renegotiating their basic contracts, managed care contracts, and thinking about what our model is. So this is really an opportunity to work with plans and providers to say, behavioral health integration isn't this thing that we hope you do, we expect you do. Value isn't something we hope you talk to us about, but we expect that you do. So trying to align these contract negotiation strategies together, I think, is a real opportunity. We run the Department of Managed Healthcare as well, which also has some influence on how the private plans work. So there's this real incredible alignment between opportunities to renegotiate contracts and influence the requirements over the private contracts to try to move the needle towards a common set of objectives around things like behavioral health, social determinants, screening for ACEs, et cetera. All right, I took enough time. I very much appreciate you listening, and I look forward to the next part of the conversation.
Great. Thank you.
All right, thank you very much. So I'm delighted now to introduce our second speaker, Senator Holly J. Mitchell, who represents the 30th Senate District, which includes Culver City, Ladera Heights, Westmont, the Crenshaw, downtown, and the Florence neighborhoods of Los Angeles. Senator Mitchell has had dozens of bills signed into law that are reforming criminal justice, expanding health care, securing women's reproductive rights, and halting the trafficking of minors and reducing the number of children in poverty. Really nice addition to this other conversation that we're having that we just heard the presentation on. My favorite part of this introduction. She's been described as the most powerful Black woman in Sacramento and California legislature's moral compass. Please join me in welcoming Senator Holly Mitchell.
Good morning.
Good morning.
So first of all, I'm very proud of myself this morning because, as you all know, your president is downtown. And I like to, have you seen the Facebook post that says that people who use foul language are perceived as more intelligent? Have you seen that? Some study somewhere, so that kind of tickles me. But I like to use foul language and talk to the people, Waze and Google Maps people. You don't know what you're talking about, you're wrong. And then they're always right. Today, I triumphed. They were wrong, and so it works sometimes if you're a third-generation Native Angelino and you understand the value of an alley. Particularly in downtown, filled with one-way streets. Wow, look, that left turn in that alley, and I'm here. So I beat Waze. Makes me very happy. It will never happen again, but today I conquered. So thank you very much for inviting me to be here and a part of this conversation. I'm glad I was able to hear a part. I am thrilled to partner. We've spent some time together already, and it's going to be a good working relationship. I, however, will not be carrying the bill for the name change.
I had to try.
Yeah, no, and I'm going to tell you why. Culture changes. Culture trumps name change. Change the culture, which I know you will do, that will trump name change. I'm also not going to carry the bill for a second reason. Your Department of Finance will go ballistic, and they will kid some astronomical figure because they have to change stationery and blah, 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 blah. And I already have enough fights with the Department of Finance. I'm not picking that fight. And the third reason I'm not going to carry that bill,
There were only two.
there's three. Case in point. California Department of Corrections and Rehabilitation. So that was an example where they changed the name and thought culture would follow, and it has not. It has taken the legislature and budget actions and us beating on the doors to make rehabilitation in that name close to being real. So you can do it because you're the secretary. Just act like it's Human Services and Health, and that will trickle down to all the people within your employ, and it will be all good. Trust me on that one. So thank you very much again. I appreciate being a part of this really important conversation, particularly with you as healthcare professionals, and not just any professionals, but those of you who are dedicated to closing the gaps and solving the problems within our healthcare system. I unfortunately have to spend a lot of time sometime trying to convince people that health disparities actually exist. And I know I don't have to do that today with you, and for that, I'm very grateful. For me, it makes this conversation much more efficient. You've got the right man in the room, and today we got some valuable information. I didn't know we were spending $7,000 per year in California on healthcare. That was very good. You will hear that repeated from me on any number of occasions. That was an important number to hear and internalize and understand, because the question for me in that moment was, are we spending it the right way? Is it enough? Is it too much? How do we equate that cost per person to real meaningful outcomes in terms of the quality of health for all California residents? So data is always very important. So I was asked, because I'm often asked in these presentations, to shed some light on the future of health policy, and I'm always like, I don't know. I don't have a crystal ball. We have a new administration. There are always lots of wheels in motion in making those decisions. We've got a new administration who campaigned and came in all ablaze with ideas, created a new position, brought Dr. Ghaly here up to Sacramento to work in partnership. So I think that we have some inclination in terms of the direction, but January budget is always the point of clear recognition from my perspective, because that lets me know where the administration chooses to put their effort. So having said all that, at least from my mere perspective, I think on a go-forward basis, at least in the next year, we're going to look at two main focuses, and they were touched on today, so I'm glad that my crystal ball is shining and accurate. I think we're going to continue to talk about cost reduction, and we're going to continue to talk about how we provide for the most vulnerable populations, and there were a couple of references to whole person care, and I will touch on that as well. Cost reduction, drilling that down to a very specific action that was taken this last year that impacted everybody in the room, I'm assuming, the 340B rebates and the Newsom administration's plans. So you all know in January this year, the governor released the executive order directing the department to completely remove Medi-Cal pharmacy services benefits from its contacts with managed care plans and instead administer the pharmacy benefit directly. This is set to happen in January of 2021. So this move clearly was a big deal. The objective, as I understand it, is to lower the cost of health care, an area that continues to balloon, generally creating challenges for employers, government sector employers, the state's general fund. I, however, was blown up, my phones, hearing from hospitals and clinics who were expressing your concerns about the impacts of the proposal to your bottom line and the impact on access to care. I heard all kinds of things that were going to happen if this became reality. You were going to have to reduce your hours of operation. You were going to have to close your in-house pharmacies. You were going to potentially eliminate nutrition and diabetes education programs. In short, all hell was going to break loose. So I was clear from your perspective how this was going to impact you. So then I had to start doing my own homework and digging deep and figuring it out. And clearly there were some discrepancies between the LAO assessment of the exact cost savings of this proposal and the governor's proposed estimate, projected estimate from the Department of Finance. So clearly I think further conversations are necessary. You all know the department provided 2 weeks for comments and for hospitals to engage in the stakeholder process. Again, we heard from everyone that that wasn't enough time for all of the stakeholders that were going to be so significantly impacted. My leader, the pro tem, sent a letter that I was proud to sign on to, asking for a little more time. We thought 60 days would be more time given the magnitude of this change. Nevertheless, the administration has moved forward with releasing the RFP back in August. Saying all that to say, where do we go from here? Clearly a project of this magnitude, in my experience, before any cost savings can be achieved, there's going to be some expenditures. There just are when you have this kind of major programmatic change. So from my perspective as chair of the Senate Budget Committee, I think that gives us ongoing opportunities to get clarity on the ultimate goal, for you all to be clear as providers about if this is the new normal, how that impacts you and your delivery system, Do you indeed no longer provide pharmacy services? I think it gives an opportunity for the conversation to continue, for the department to hear from you, even if it's out of the formal comment period. And I would strongly encourage you all to continue to engage in the stakeholder process. You have to stay at the table to help policymakers, help the administration for that matter, really figure out what's going to be least disruptive to our current system, and yet meet the goals they've laid out in terms of identifying cost savings. Again, I think the budget process will be an interesting point in time where this conversation can continue. Because as I've experienced over the last 10 years there, we have these great ideas around cost savings, but they require investment. It requires investment either in technology, it requires investment and the investment of time to alter a course, a pattern of practice before we can really begin to quantify what the true savings are. Again, there are systemic processes for working on this executive order, and I hope that you all will stay engaged. The second piece I think that's going to be clearly an ongoing conversation, particularly with the data that was shared, is really the health homes model. And the director's right, the secretary's right, that is something that I've been involved in for a number of years. Back in 2013, actually my first year transition over to the Senate, I authored AB 361, which authorized the state to take advantage of an Affordable Care Act optional Medi-Cal benefit, now referred to as the Health Homes Program. AB 361 funded housing navigation and tenancy support services to help Medi-Cal beneficiaries experiencing chronic homelessness. The governor signed the bill into law, but total implementation of health homes was never fully actualized, primarily due to the recession and the ensuing budget cuts. But thankfully, today we're in a new place. This year I worked on Senate Bill 631, which would revamp the health homes program. I was asked by the administration, and I complied, to put a pause on 631 and make it a 2-year bill. We'd gotten it over to the second house because of the new focus around whole person care. And I'm excited about those opportunities and want to be fully engaged and be your supporter and partner in figuring out what whole person care looks like for California. I don't have to talk about the need in this room. The data was very clear in terms of the chicken versus egg analogy. We've got to really deal with the whole person and all of their life experiences to begin to make a significant dent in altering some of those numbers that you saw on the board. I think I'll stop there because I know you want to do a Q&A and we have the opportunity for us to work together. Suffice it to say, I'm thrilled with the direction the new administration is leading all of us. Just like you, I'm a California resident and I'm a voter too, separate from my day job. And when I think about what's important to me and my community, I'm very happy that we're able to have a data-driven conversation, that we're able to step back and acknowledge many of the strides California had made in terms of covered California and new populations that we're providing coverage to. And yet, as I travel my district and have conversations with thought leaders in health and residents and beneficiaries of services, to hear data like Compton, California, has the highest rate of amputations of anywhere in the country, takes my breath away. To understand how we got to that place in terms of the lack of access to appropriate community-based services takes my breath away. And so we've got a lot of work to do. We've got the resources now. It's been a privilege for me to continue to be a leader in the state budget process, considering when I came into the legislature in 2010, the first budget I voted for was $88 billion. And the budget I led and voted for this June was $215 billion. So the state has experienced an economic recovery. The general fund is healthy. This year, we put more money than we ever have in the history of the state into various rainy day savings accounts to help prepare us for the next recession, because it's going as my Jamaican brothers and sisters say, it's going to soon come. It will soon come. And we want to create a situation where the most vulnerable, those who depend on government services during times of crisis and economic peril, that we're not in a position where we continue to contract, grow again, contract, those kind of programs. To acknowledge that California ultimately eliminated Dental Cal was really one of the driving issues that compelled me to run for office, because I was just beside myself. And the time we have spent to try to rebuild a program, get providers back into it, get beneficiaries aware that, oh, we're doing Dental Cal again. You know, that start and stop is really challenging in terms of the infrastructure, as well as beneficiaries knowing what services are available. It's awful. So I don't personally want to ever go there again. And so that's what drives my budget actions in terms of spending sensibly today, saving for the future, but making sure that Californians have access to the resources and services that I believe they're entitled to. And healthcare services is at the top of that list. Thank you.
So if I could invite both of you to have
Sure.
a seat over here. We're going to go ahead, so those questions that have been brewing, that I know you have, because I heard about them before we even started this session. So I'm excited about that. But what I want to do before we get your question started, or to give you a chance to write down your question, I want to invite the two of you to offer, Mark, if you want to offer a reflection to Senator Ghaly of what you've heard, a question that you might want to ask of each other, and then we'll open it up.
Well, one reflection, because I think we share this common knowledge and commitment. Not far from here, South Los Angeles is a place that has an incredible story, but also a sad one about the persistence of health disparities. And we opened up a hospital there after, in the ashes of an old MLK hospital, opened up a small private hospital that today, because some of the access challenges in that neighborhood, not just the lack of primary care, but frankly, outpatient specialty, 110,000 ED visits a year, almost the same size as our biggest county hospital. Really as a narrative about this inequality across the state. And not far, right, in the West Side, Beverly Hills, those of you who know LA, there is a wealth of all sorts of specialists. And we have to, I appreciate your leadership on thinking about how do we use our influence with policy and budget to try to change that narrative. And it's a hard thing to do, but I look forward to the day when our common friend Elaine Batchelor is reporting to us that, look, we have a lot fewer people coming into our EDs. Right. We're no longer the town noted for the most amputations that are avoidable because of diabetes. Right, like that story can and should change. And I would just echo what you said, that we have the resources in a way that we may never have again, or at least for a while. So how do we wisely make some investments in shoring up that system in the places that need it most? And so it reminds me of a word that I know we both think a lot about, but we didn't utter it nearly enough, was this concept of equity in healthcare, right? And when I think about raising all boats, I know that not every boat's at the same level today, and although I want to raise all, truth be told, we want to raise some to get near or equal to many of the other boats. So I think that's one of the opportunities that I see us working on together. Many of the things you support sort of lead into that and allow for that, but I think we can do more, and I'm excited to partner with you on it.
Hear, hear.
Great. All right. So raise your hand if you have a question. And what I'd like you to do is introduce yourself, your name, your organization. Yes. And then if you want to direct your question to a particular individual, just say so. So Ellen, am I going to start with you? Okay.
Hi, Ellen Pierno, Chief Medical Officer for Golden Valley Health Centers. What I wanted to ask you about is, with the changes to public charge, we are seeing a lot of our folks receding back into the shadows. Is there anything that the state is planning to help us sort of, bring those people that we've spent years trying to bring out of the shadows back into care?
November 2020. How about that?
Start there.
November 2020, wherever you are.
Yeah, I'd say we, the Health and Human Services Agency, with the guidance of a lot of people, just put out a sort of guidebook on what to do and where the state is and what it really means. And, we're getting closer to October 15th, right? The idea that there's a lot of people who should be getting care and access to services in the next few weeks before the, quote, chilling effect really could take place. I think spreading that news now, it makes me think about some of the things that you all have done, which are reminder calls and get people in and do that now as much as you possibly can. I think it provides some clarity on which programs. I mean, the chilling effect is so much bigger in this area because if you look at what's actually impacted, I don't want to minimize it. It's an enormous thing, but I think the noise around it is enormous. So what can we do in those opportunities with reminder calls and sort of any engagement to make sure we get people to the informed advisors, legal advisors on what it means for them? The state put in some extra dollars to help beef up those legal resources. If you see an island out there, we want to hear about it because we don't intend to have an island of where that resource exists.
Right.
So those are things we're prepared to do. I think, the sort of the playing offense and defense in this whole thing, we're a little, we're trying to be smart and defensive. So putting resources where we think we can kind of bring truth to the myth and see where it goes.
I would just add that the answer really is on you. We're government, and people have a distrust of government. And so when I try to say, oh, it's the federal government, not me. And I get that. And so before running for office, I ran Crystal Stairs, largest child development organization in the country at that time. That was during the time of Healthy Families and the application assistance. And as a nonprofit, we were the top enrollee for the state. Why? Because we had a 30-year established relationship with the community. We had a track record in terms of providing them a needed service, child care. And all I did was have my intake and eligibility workers add one question to the interview. Do you have health insurance? Do you have health care? Oh, you don't. And then we could pivot. And so you have the established relationships. And so we will do what we can. We did put money in the budget for legal, and we will do all that we can. But you're the front line, and they will trust you before they trust the two of us. And so we have to partner in terms of all of us staying in our own lane. We're going to do all that we can. But you are who they trust. You are their provider. And so if you say, please come and this is why, it will go further than any conversation that can be started at the state level or from any government official, in my opinion.
Okay, we have a question over there.
Hi, my name is Gwendolyn Guys. I'm with Kaiser Permanente, and I have to just say I'm just so excited to have the both of you here today having this conversation. And I'm so excited, Doctor, by your leadership and your boldness about what you think about this. And think of you say the whole person, and I always talk about Mr. Johnson. Because Mr. Johnson doesn't experience healthcare here or there. He experiences it everywhere.
That's
so
right.
I'm very focused on what we do for Mr. Johnson and how we address his all of his needs, including his social non-medical needs. And so as you two mentioned health homes, I'm glad you brought that up, and you mentioned whole person. It would help us, if you could help us by helping create a framework for how you want us to deliver the outcomes you want and give people the room to be creative and innovative. Because I think whole person is well-meaning. I thought health homes is well-meaning, but when you think about it from a delivery system perspective of trying, come on now, we're having church? Okay, got it. About how, is there a question? But how you want us to show up and deliver that, give us room to do that. I think whole person was well-meaning. I was, before my current role, I was in charge of all of Medi-Cal for Southern California at Kaiser. And so implementing whole person, implementing health homes has been I'm gonna
I
leave
get
it
it.
there.
I get
so,
it.
So I'm gonna leave that there. So we appreciate the fact that you're taking a pause and looking at that. And while you're at it, how are we gonna really integrate behavioral health into the conversation in a meaningful way? Okay, thank you for your time.
She looked at me. The good news is I have some ideas. So one of the things, and the Denti-Cal is actually a very telling experience, right? You had this investment, we took it away, the infrastructure folded up, and then we say, oh yeah, we're coming back, and then you expect it all to build up again overnight. And I think where we are now with health homes and whole person care is these have been pilots or limited in terms of the number of months we're going to invest in it. And having been in many of your shoes, it's like, how do you plan for that? How do you agree to go up with millions, hundreds of millions sometimes of infrastructure investment, staffing up, to wonder, is this going to get in the budget next year? So really the trick is how do we build it into the core infrastructure of what we fund? And I think that's where we are now, is asking the question. So you'll see two things. First, when you try to build it into the foundation, you take it from this sort of on the fringe, yet exciting program that for some is a distraction. You try to build it into the fold. You do two things. You do some of that, but you don't do all of it. So you'll see in the months to come a conversation around how we think about our next go at the waiver and building it into the core of Medicaid. So it's part of rates, if you will. We've got to be pretty creative. It's not been done at the scale California wants to do it. But it may not do everything people are used to because we can't take it all on day one. So my hope is, and really the conversation we had with Senator Mitchell about health homes in your bill is, we need to build this into the fabric of what we do. And then the second thing I would say, and this is, there's been a lot of excuses why the health entities haven't done this because of kind of this fits and starts and it's hard to do. But guess what? We don't solve social determinants in the four walls of a clinic or with the people we hire. It's going to require a significant degree of engagement with community partners, both that get big federal dollars, like on the social services side, but those trusted faith-based partners, school partners, et cetera, to really make this work. So we're going to, and I know everybody in this room is like, yeah, we can do that. But frankly, we haven't done it very well. We don't have the necessary MOUs and business agreements. And it really is, it's going to be a business agreement, right? There's going to be money that flows out of the health system into those support systems to get people housed, to get the kind of case management that isn't same person with 4 case managers. It's going to take some effort. And we can't expect folks to do that if we haven't built it into the fabric of what we pay for. So that's our mission right now. Let's stop it from being a fringe idea where I show a bunch of slides and people pat me on the back for doing it to, look, you guys want it as a core part of the program and so do we. And then we can deliver and talk about the outcomes.
And I completely agree. And I was clear it was a fringe idea in 2013. But if we didn't have the bill and start talking about it, I don't believe we'd be here today. Just saying. And so and at that point, the administration didn't support it. We went round and round and round. I had to push. And we're here today in a very different place. And I completely agree, and which is the reason why I was more than happy to put a pause on my bill, because I wanted to be successful. It was a piece of the equation, but if I now have an administration that's talking about federal waiver for whole person, my work here is done.
Thank you
It's in
for
your
getting
lap.
it. Yeah.
I can move on.
I have a bad feeling that the longer this goes, the more I have to do, and she's and she'll call me and say, there were 5 things you said you were going to do. And, okay.
This friend speaks my mind, very much so. I've been pretty much in the trenches. I'm sorry. I'm Laura Miller with Community Health Center Network, a we support 8 federally qualified health centers in Alameda County, and I've been in the trenches of building a health homes program from about 2013. And I have to say that many of the gray hairs on my head at present are related to the administrative burden and working with 2 health plans and 2 different kinds of spreadsheets, and they flip the tiers one to the other. It's been, I love the program. I love what our community health workers do. And as you think about rolling it forward and keeping it moving, I would really put in a plea for streamlined processes and something that is really easier to do.
And no silos, which is what he said.
Right. And what are your thoughts on streamlining it, making it easier going forward?
I like that idea.
You're all for it.
So, another piece of what we hope to achieve as we, let me just say, waiver conversations are exciting. If for no other reason, it forces you to take a step back and ask, what are you doing that doesn't make any sense?
Right.
And what do you want to do?
Right.
And on this, the notion, I spend a lot of time talking to the DHCS team about simplification. And people get scared of that a little bit because some of the innovation has come because of the complexity we've created. So there's a group of people, they're maybe not in this room, that are nervous. Man, simplification means some of the innovation, because it's harder to follow the bouncing ball if it bounces a bunch, right? So some people see that innovation coming through that complexity, but we are of the mind now that from a delivery perspective, you've got to move towards simplification. So how do we take thousands of aid codes and turn them into less than 100, right? How do we create regulations and books of guidance that are this thick down to this thick? So we are thinking about how in the upcoming waiver conversations we move towards that. And I agree, as you think about kind of partnerships between healthcare and some of our social service partners as part of, how do we use Promotores and CHWs? And you guys have been leaders in that work. I've been impressed when I was in LA about some of the work you guys did in Alameda on this front. But how do we make that easier so that the workforce that is becoming the new health workforce isn't complicated and sort of disillusioned by the fact that they've got to do things in this way that many of us have blindly accepted for a long time. So it's not just how do you interact between provider and plan, but how does your workforce actually do their job well? And I think we put them at a disadvantage because some of those rules. So that's what we're seeking to do as well.
If I could just add very briefly on simplification, because I hadn't thought about this in years. The other danger in simplification, I experienced as an advocate for the Western Center on Law and Poverty in the late 90s when our goal was simplification. We also, by doing that, separated Medi-Cal and its application process from everything else. And so we, pardon my language, bastardized the other social services because we didn't want you to have to go into the Department of Social Service to apply for Medi-Cal because that was such a horrible experience. Well, by pulling the Medi-Cal experience out, online apps, all that we did to simplify the Healthy Families app, that also disconnected people from other services they qualify for. Because there wasn't an eligibility worker to ask those questions. Okay, well, you qualify for this, but tell me if you have any kids in the family, Those questions that lead to you getting the other social supports that you had on your chart here that they qualify for. And so we wanted, to make healthcare different, make healthcare for all. We didn't want to be associated with those other poverty-related programs because, poor is bad. So in our effort to simplify, we let down some of our other services, and we let down the beneficiaries because they were no longer in an environment where they could learn about the other supports. So we have to learn from past mistakes.
That's a good point.
Hi, I'm Giovanna Giuliani. I'm the executive director at SNI. We're the performance improvement arm of the public hospitals in California. My question's about cost accountability, and I know we've been hearing a lot from you guys both today and from the governor and from Seema Verma, who's talking increasingly about accountability at the federal level. And I'm thinking about it from the perspective of the public hospitals and healthcare systems who, have had a lot of funding on the line through the waiver and Prime, but to really advance that capability into a much more sophisticated approach, if you will, is going to take what Senator Mitchell kind of called the upfront investment. In order to save money, we're going to have to invest money. And I'm just curious about your openness to that, how you think something like that might play out over the course of a couple years under Governor Newsom's reign.
So, I've been a public hospital person for a while. Even though I moved jobs, I didn't move away from that commitment, right, in LA, because it comes home every night when I'm home, right? My wife runs the LA County Public Health or hospital system. So we talk a lot about it. And there is this constant struggle, right? I've spoken to leadership about it, because this idea that that it would be a new idea investing in that is just not true, right? Like, we've been investing, right? This is our fourth or fifth round of waiver, really, that has been there to support the public hospital system. And I think that, and we continue to do that support because it's such a vital piece of the network, right? I mean, I often have been attracted to the public hospital space in part because they as a collection do work that very few people are equipped to do. And we do have to make some investments, more, ongoing investments into that sort of cost containment concept. But I would also say that we need to continue a conversation about how the public hospitals recast their identity, right, in the whole stream of the delivery system. And one important place that I hope that the public hospital system will continue to lead in is by, and I said this when I was at Southeast Health Center in Bayview Hunters Point, thinking about how, frankly, in the safety net, quantity or the volume of people you see is a quality measure, right? Because frankly, what people need is access. And when we don't get enough people through our door because of whatever excuse, they're hard to get in, they don't pick up the phone, our docs, who hasn't been at the clinic with the hardest patients? Everyone does, right? Like, I haven't met a
They
clinic
miss their appointments.
right. So the idea that the public hospital system and clinics, and frankly, our FKHC partners, the same, how do we make sure that we're using the full ability to engage and have our patients in, and that, frankly, from a cost containment perspective, the systems, the public hospital systems, have these enormous fixed costs, right? Infrastructure, staffing, all of these things. One way to make that different from a value perspective is to get more people in. So when I see 6 to 7% of California still uninsured and frankly not having access to primary care and outpatient specialty in a thoughtful way, I see the public hospital system as a place to help solve that and get it from 6 down to 3.
So can I ask you a question? So we have, would you be able to take 2 more questions?
Sure, I have
That timing-wise work?
there, so I have no idea what time it is.
Perfect,
So
great.
if you make me late, it's my own fault.
I like the sound of that.
Michael Rothman, Executive Director at the Center for Care Innovations. And my question is about how we address the social determinants of health, which you've talked about as the most important drivers of health in underserved communities and your key goals for HHS. So climate change is maybe the biggest growing current and probably long-term social determinant that's going to affect the health of underserved communities, from heat events and average higher temperatures, water, air pollution. What should HHS be doing and will be doing in the regulatory and purchasing role? What should payers be doing? What should providers be doing to prevent and reduce emissions that drive these events, and being resilient when those health effects are happening in our communities?
Yet again, small question. Well, I think it's an increasingly relevant question, right? So I think about the wildfires, which I now have in a way that I never thought about before, because I have a responsibility to respond on a number of levels. And we see what has happened with sort of these increasing number of events, and nobody in Sacramento thinks that it's getting better soon, right? Our response will hopefully be more timely and better, but the number of events until we really make some impact on climate change, we don't see it changing. So on a very basic level, you look at Paradise, and I mean, we have still a lot of people not in a home, not their home. Like, that's a lost idea. So when you think about the whole climate change notion, one of the first things I think about is, okay, how do we respond to the fact that we're living in an environment today where the risks and the problems of our past behaviors, right, are really in our face every single day. So supporting our response and making it bigger and better, I think, is something we are trying to do more of. The department I didn't spend a lot of time talking about was the Department of Public Health, and we have an Office of Health Equity. And when I first came and sort of said, hey, so what do we do in that office? And it's actually all about climate change right now. The number one equity issue at the Office on Health Equity, and I hope to diversify their portfolios so that we have some other areas of, quote, health equity as the focus, but the fact that we have a number of leaders there, and I have the privilege of sitting on a set of other cabinet secretaries who are thinking about how the Strategic Growth Council, which is one of the key investment arms at the state on climate change, how we actually come together and have what they sort of call health in all policies. So how does the health of the community actually impact and affect what we're doing on building the built environment, transportation, et cetera. I haven't given it a lot of thought. It's actually an interesting question on how we can set some expectations of our healthcare partners on how they use both the opportunity and the responsibility that the state gives them to affect and certainly not contribute in a bad way to the climate change impact. And I'd be open to ideas. Like, I think, wow, we have these contracts coming up. How do we build that in? And, you ask the question, I'll ask you, what are your ideas? How can we support you to do those things that make sense?
Great. Okay, we have one last question, and then we'll wrap it up.
Great. Hi, Cynthia Carmona. I'm the Senior Director of Safety Net Initiatives with the LA Care Health Plan. And we just launched Health Homes in July, and we have a small but mighty team that is very adaptable and flexible and genuinely excited about the promise of that program. So thank you for doing all that legwork. And our direct relationship for the first time with the PCPs in the community and the county that are bringing on the care managers to do that work. We've enrolled almost 800 people in the 2.5 months that we've been live. So we're really proud of that work. I think in thinking towards the future, we're going to be setting up a regular working group with our county to start thinking about how do we think about whole person care and health homes and all the interesting things that might come of that. But I think 2 questions. I'm going to do 2 for 1 on this one. So I guess for Mark, the question is, as we start to think about building those non-traditional connections, how are you kind of doing that in Sacramento? I know you try to make a point of doing that internally within your own vertical, but what kind of conversations are you having even outside of HHS to help kind of push that dream forward? And then for Senator Mitchell, I guess my question for you is, I know Mark's going to do all of it, but kind of based on your initial vision of health homes, kind of what are some of the intriguing things that you've been thinking about in terms of what could happen in the next year or 2 that has kind of put on a light bulb in your head to say, oh, that would be really interesting?
Got it.
Do you want to go first?
Sure. From crisis comes kind of creative thought and invention. And what's difficult for me, having moved from nonprofit sector into government, is, we don't innovate. You do. And my desire has been to make government's response a little more real time, and to do all I can to remove barriers to your innovation. And so that it needs to be a two-way conversation. You know, we don't sit, at least in my office, and Team Mitchell, we don't sit, we call it under the dome, and just come up with these ideas based on our life experiences. It's relationship, it's input from partners, Dr. Batchelor at LA Care, with your amazing leader, with the Community Clinic Association, who came to me in 13 and said, this is an opportunity, let's roll. So we've continued to have conversations about what's not working. We need you to push the department here. How do we make this flow? And so we've been engaged with our ongoing partners at the clinic level, in the housing space, in the homeless services space, to really figure out what does it look like on the ground, going back to your point. It's one thing to think about in theory. So that's what 613, how the new bill, 631, 613, whichever, was born out of, to really figure out how we take it to the next level. And so how do we operationalize it at the community level? As budget chair, what can I do to maybe not eliminate silos, but make sure that funding follows the person? So that was the thinking behind this next iteration. Since we're in a position now where we've been able to rebuild, we've put more money into Medi-Cal, expand it to a broader undocumented population, trying to address issues around increased reimbursement rates, because that's what Dr. Batchelor's in my ear on. Holly, it's great that you're expanding eligibility, but we need more providers. So it's all of those experiences and conversations that have helped kind of fuel the conversation. And I want to be at the table as we talk about whole person care and what the waiver looks like and how it would be relevant to California. So all of that.
So I'll try to be brief. In the past couple months, we've prepared. Next month is sort of the launch of the official, quote, stakeholder process on waiver conversations. I think many of you know we're calling it Cal AIM, basically, achieving improvement in our Medicaid program. And for the first time, I feel like in the history of my agency, we've actually had, and it hasn't been easy every day, but really forcing our healthcare services leadership to bring that idea to all the other departments, right? So I've held a series of meetings in my, quote, executive team where we have DHCS. Here are our ideas. These are the initial ideas. How do you want to engage? So I have social services and healthcare services at a table talking about how do we take the homeless-focused efforts and things like whole person care and health homes and tie them into what we're doing around CalFresh and, frankly, some of the housing assistance there. I mean, this neat idea that one day I hope we have a federal administration where I can boldly go and talk about what some of us have called this sort of mega waiver, but this idea that we can have social service dollars coupled with health dollars and HUD dollars and actually bring them together to serve that whole person in a way that we can't. I mean, to try to do this all on the backs of Medicaid is not easy. Mm-hmm. And, I'll be the first to tell you that we don't have a lot of equity tools in our toolkit, but Medicaid is one of the most important equity tools. I mean, it is a health tool. I don't want to dismiss that first and foremost, but it's one of the most important equity tools. So for me, it's making the connection between healthcare services, who sort of owns the waiver and those conversations, and everything we're talking about in terms of our relationship with health plans, but making those connections with all of the other departments. And it doesn't stop at health and Human Services, but it's conversations with the department, the corrections groups, it's transportation.
Caltrans.
Caltrans is a big one. I mean, all of these things. So we're bringing them into the conversation, probably for the first time ever in a waiver conversation, because it's largely been, hey, this is a healthcare services thing. Right. No, it isn't. Right? It's one of our few equity tools that we have. Right. And then secondly, I share that because I think that I hope will be the model of what health plans do, right? So we are essentially going to double down on a commitment to health plans. Like, look, you've got to be the effector of change in a way that goes beyond just, hey, how are we working with our IPAs and our clinics to get quality scores up? It's like, do we have the chops to connect to housing providers, transportation providers, et cetera, that actually make a difference in the whole view of the life of the people that we get paid capitation to take care of their diabetes for. I mean, it just doesn't make sense. So the same sort of infectious hope I have at our state level by bringing everybody to the table, and they're not always comfortable. I mean, you should have seen the first meeting. Oh, nobody talked. But I was like, well, here's one connection, here's another connection. How's DD here? How's DD? I mean, it was not easy. The second and third, a lot of unique tables coming together on how, like, regional centers sit over there. How does that make any sense, right? So there's all of these opportunities, but we need that to happen at the local, county health plan level as well, because we can't do it on our own.
The Australian government, a couple years ago, created a set of core principles in their budgeting process that every department had to acknowledge that they had a role to play in. And it was issues around equity. It was commitment to their indigenous people. I mean, it was a phenomenal progressive set of 4 principles that every department had to show in terms of their budget ask that they were meeting those 4 principles. And so whole person care is an opportunity to create this set of principles that everyone has to step up to the plate. So when you meet with the Caltrans director, like I did a couple years ago, and I said, you know, let's talk about homelessness, and I kept being told about what the mission of Caltrans is. I said, oh, okay, you don't get it. You're a landlord because people live on your property. And you keep reciting to me, the mission of Caltrans is safety transit. I'm like, no, it's not. And so an opportunity for all department heads to look at a set of core principles, in terms, whatever they may be, in terms of making California a place we all want to, you know, grow old in and raise our children, whatever those principles are, that's the kind of thing that will get us to a place where those kinds of cross conversations aren't so structurally.
They're not forced, right?
Right.
You hope, and
They're innate.
we took your exact concept and the guiding principles that we have for we're sort of in the create your budget requests now. Those are, we have a checklist at the top before anybody can submit something. They have to make a connection to these things before I even want to see it. So hopefully that becomes the way we do business over the next handful of years. All right, we'll stop.
So on that hopeful, future-looking note, I want to say thank you very much to both Senator Holly Mitchell and Dr. Mark Ghaly. Thank you for joining us today.
Thank you for having me. Appreciate it.